I'm absolutely delighted to be invited to give a plenary lecture at the GBCC, and indeed honoured to be so. It will give me the opportunity to bring to the audience the most recent results and to also give the challenge of interacting with them and answering, I'm sure, their demanding questions. Yes, I've heard of both, and I do know one or two members of the Korean Breast Cancer Society. And indeed, I've heard a great deal of very good things about the GBCC. I talked to a few colleagues that have presented at the meeting before, and they've told me what a good quality it is, and that I should do my very best to actually accept the invitation. So I was delighted to be able to do so. My lecture will be about the use of and the, if you like, the exploitation of the opportunity for treating breast cancer before it's surgically removed, pre-surgical studies. We've done a lot of work in this area, and many other groups have as well, of course, and I will draw on both our own work and that of other people. I tend to divide pre-surgical studies into two groups. One, the conventional type of neoadjuvant treatment, where the goal is to downstage the tumour, and as well as to try to understand response to specific treatments, but perhaps more of the window of opportunity studies, the way in which we use this window, which in the UK is around about 2 weeks, between the time of diagnosis of a patient and the time they go to definitive surgery. This, of course, is a time when the patient would normally get medical treatment, but it gives us the opportunity to provide treatment in that period, and to use biomarker to understand whether or not the patient is responsive, whether or not the tumour will respond, but in a biological fashion. It's very uncommon with the endocrine treatments, which we do most of our work with, create a shrinkage of the tumour during that time. So we use biomarker to assess whether or not there is a response, a biological response. And most frequently used biomarker is Ki67, Ki67 as some people call it, and measure of proliferation. So we've done many studies in this area looking at drug development, new drugs, particularly new hormonal drugs, and this continues to be an area of interest with some of the new selective estrogen receptor downregulators being assessed and compared with our established drugs like the aromatase inhibitors, tamoxifen, and sometimes even some of the GnRH agonists or GnRH antagonists in premenopausal women. We've done a number of trials of this type, looking at, say, at drug development, looking to develop new drugs, to understand those new drugs, how they work, particularly which sort of patients they might work in, or just as much interest, which sort of patients they won't work in. Begun to look to see if we can bring this to routine clinical management. I should say, for the moment, the window of opportunity for patient selection for who should get particular treatments is still being exploited more in the clinical trial circumstance. And I'll discuss in the lecture 3 of those trials: the ADAPT trial in Germany, the alternate study of Matthew Ellis and Cynthia Marr in the US, and then a new study which we've started called Poetic A in the UK, using this window of opportunity to select patients that then randomized to receive an aromatase inhibitor with or without the CDK4/6 inhibitor, abemaciclib. Perhaps somewhat unusually, we're stratifying those patients according to a molecular signature called the AIR-KISS, that's AIR-CIS, AIR-KISS. That stands for the aromatase inhibitor resistant, CDK4/6 inhibitor sensitive population. I've tried to start it. I'll explain what the concept of that is. And lastly, I'd like to talk, somewhat of the way in which we've been using this pre-surgical window to understand better the mechanisms and more often the biomarkers that are associated with response and resistance. And we've been particularly interested in the recent past to see that, to some extent, a surprise that immune features, immune signatures are the dominant features for resistance to hormonal agents in our most recent studies. So I'll be doing a broader selection, different aspects, different concepts for pre-surgical treatment and its research. So I'm not a clinician myself. Many people think I am because I spend so much of my time alongside clinical colleagues and collaborating with clinical colleagues in our research. The vast majority of our research has been what one would call clinical research. But given that, it does make things a little difficult for me to talk about managing career development for clinicians outside of the time that they spend with me. And I have had well over 30 young clinicians spending 2 years at a time doing research projects now in our laboratory. And at least for that, I can certainly say, I think most of the vast majority, in fact, of the young doctors enjoy with us. I would say that they should just throw themselves into it with enthusiasm. Don't be too concerned about the new challenges that are there. And after the clinicians have left the laboratory and gone back to their further career development, they do, I think, benefit from both the time they spent with us, but also continuing to engage with research. I think it's a much more rewarding career. As for breast cancer is, for most people, a very rewarding career anyway. It's a challenging area to work with. It's a very diverse area, complex area. And if the clinicians can pick an area of research, which they might not be doing the laboratories analysis themselves, or indeed have a lab themselves, but collaborate with scientists that are generally only too willing and enthusiastic to collaborate with other clinicians. So those are the things I can say, I think, that I've seen help the development and enjoyment of medical careers in the UK. Well, personalised treatment continues to be the thing that we focus on, trying to, instead of thinking about how drugs actually impact what large population, trying to understand better the delivery of those drugs to patients who will personally benefit from them. This will mean, I think, more and more focus on biomarkers, linking those biomarkers both for prognosis and for their predictive value in particular, as to whether or not the patient, because of their prognosis, actually has such a good prognosis, they don't need additional therapy beyond perhaps the hormonal therapy that they're getting at the moment. But then if they do need further therapy, which of the therapies they will benefit most from? And one of the real challenges is that, in breast cancer is that once we perform surgery, that tumour is removed, and although we might think about the patients for many years thereafter, we don't know whether the patient's responding or not. Nothing to judge it at the present time. And I think that's the other thing in terms of keyword, circulating tumour DNA as a keyword is an area which I've been not so involved with myself, although closely collaborating with colleagues at the Royal Marsden. It's an area I've been really enthusiastic about for several years. I think it could really revolutionise, it'd be a step change in the way in which we treating patients if that circulating tumour DNA can be sensitive enough to actually detect and sometimes to characterise molecularly any underlying micrometastatic disease. And if we can see that there is no micrometastatic disease or very limited, perhaps we don't treat the patients any further with their with adjuvant therapy. We would monitor the patients going forward, hoping that they actually had indeed cleared any micrometastatic disease from their initial treatment, but then being able to step in very quickly if there was a suggestion that the circulating tumour DNA is increasing. There are many trials, some of which, again, my colleagues are involved with and leading, that are asking whether this will indeed be the case. If it is, I think we really have a major improvement the way in which we manage patients. And the next 5 years should be the time frame within which we'll understand that better. Well, I'm sure you'll enjoy the conference. I hope you'll go home knowing a bit more, understanding a bit more. I think the one extra thing I might say is that when you're having your refreshment break, do take the opportunity to talk to your colleagues, and not just your friends. Speak to the other person that's standing there drinking their coffee alone, who would just as much like to speak to you as you speak to them, but perhaps a bit shy, and say to them, what have you enjoyed at the conference and what have you found challenging? And I think that can really help individuals and actually help the conference as a whole. It's actually discussions with colleagues that make these conferences so much more worthwhile.